You're now live on YouTube, Chair. I'll leave you to it.
Okay, thank you, Gordon. He's trying to leave. That's right. Okay, welcome everybody to March's meeting of the Rotherham Clinical Commissioning Group. We have apologies from Councillor Roach and our Director of Public Health. So otherwise we are all here and therefore we are quorate. Are there any declarations of interest above and beyond the normal declarations of GPs? Okay. Are there any patient or public questions? I don't know if Ruth is frozen or do we have any patient or public questions, Ruth?
Oh, no, we've not received anything.
Okay, that's great, thanks. In which case, we'll just do the draft minutes of last month's meeting for your accuracy and any matters arising. Note there isn't an action log from last month because there was nothing outstanding. So page 1, page 2, 3, 4, 5, 6, 7, and 8. Okay, well, thank you, Lindsay. They're an accurate record. We'll move on straight on to Chris then with the Chief Officer's report.
Thank you, Chair. Just open it up. Okie doke. So just quite a short report this time. The first bit of the report's around the outcome of a request for a quote process for a suicide bereavement service. Obviously something we're very concerned about at the moment. So especially with COVID amplifying the issues we've got in this area. So very important we get this service. So just in the spirit of transparency, we're putting this in public session, and the listening ear was the successful provider for both services, which are detailed in the notes, for both a suicide bereavement support service for those affected by or bereaved by suicide, and a COVID bereavement source for those who experienced bereavement during COVID. So obviously it's a very fast moving agenda as we speak. And those services will be funded from the NHS England suicide prevention monies, and it'll operate across Barnsley, Doncaster and Rotherham. But Rotherham CCG's act as the lead commissioner, so hence we're obviously disclosing this publicly. So just pause to see if anyone's got any questions on that, but it's more a case of just transparently doing our business. Okay, I'll keep going. In terms of comms update, the major focus of communications activity obviously is the vaccine rollout, obviously all over the national news and very important for us locally. The Rotherham advertisers working with us to give messages out to the Rotherham public. I think there's a big feature coming in next week. And we're looking about the availability as we move down the high priority groups, and also as we move to second vaccinations as well. And there'll be a slight change in how the model works as we continue to look to the larger vaccination centres, and also potentially community pharmacists is coming into our model. So we'll keep communicating as the model evolves to cope with the bigger numbers that come through. I think that covers it for the Chief Officer's report. So I'll just see if there's any questions, Chair.
Questions for Chris? No. The only thing to raise is, have we got any positive feedback about how the bereavement services work so far to support those people? So obviously we're extending it just to publicise it a bit more.
Can I come back on that?
Yeah, okay.
Chris?
Please.
So, can you hear me okay? Sorry,
Yeah, I
Chair.
can hear you fine.
Yeah, sorry, okay, thank you. Yeah, so a bit more detail on the service, Chair. I think two elements to it, as Chris was describing. The suicide bereavement part was in response to our increased incidence of suicide over the previous 18 months, and then we chose to bring in a listening service to support families and carers in that space, which has proved really successful. So we've then extended that as part of the bereavement support for people that have experienced bereavement as a result of COVID. And the whole approach with this is that it is a listening service where individuals can are informed, their families are informed, carers are informed of the service, and they can then access those services maybe a month, maybe 2 months, maybe 6 months down the line post bereavement of a close one, relative, etc. So the service is then available to individuals to access accordingly, Chair, with regards to at any point in time they can then access that back. So we've had some really good feedback from that, and again we're just going to continue to roll that forward now with other South Yorkshire areas wanting to build on the good practice of what we've done in Rotherham, hence it's more of a joined up approach.
Great, thanks Ian. Any other questions? Just moving on then to integrating care next steps update, Chris.
Unmute myself. There's just 3 things really to report. So we haven't had any further documents published since we last met, since the white paper. But the 3 next steps, I guess, is we're expecting an operating framework for the year 21-22, or the transition year as we're referring to it. We're hoping to get that this month. So I'd expect that to come to April governing body, assuming it comes out in time for our papers. Then in April, we're expecting a publication of the human resources framework. So again, that's something we'll need to consider as an organisation to make sure we have a careful transition to the new world of CCGs transitioning to ICSs. And then the next bit will be in May, when we're expecting to see draft legislation as well. So there are 3 key documents we'll need to consider as we move forward. And what I'll do is when they're available, the documents will come to this meeting and we can consider them in public and work out how best to implement them for Rotherham patients, services and Rotherham staff.
Okay, thanks Chris. Any questions, comments for Chris on that? I think it is just at the moment just a waiting game, isn't it, to see actually what definite stuff comes out nationally. Okay, strategic updates then. This is you. It's normally Ian with all the papers, Chris. You've obviously been busy this month, so you're putting all papers on yourself.
So again, this is a paper that we receive every month. It's from Sir Andrew Cash, as the Chief Officer of our integrated care system. So as in the normal routine, I won't go through the paper in detail. It's here for information and transparency, so if people have got it. But I'm more than happy to take any questions if anyone has any questions on the paper.
Okay, Jeff.
Yeah, I think there's a paper further on, Chris, about the green economy in terms of savings and things. There's just a bit at the bottom about infrastructure and a thing about slippage is offset forecast unplanned charge of 9.5 million to Rotherham Carbon Energy Scheme. Is that like the ICS that pays that, and what is that, and does it affect us as a CCG?
So the Carbon Energy Scheme is a scheme that Rotherham Foundation Trust, the Rotherham Hospital and Community Trust as we know it, entered into. So it's something that affects the Hospital Foundation Trust, not the CCG.
Okay, thanks.
Okay, thanks. The white paper is just for information as well, isn't it? It's Chris.
Yeah, so the white papers again here, we've covered it in we've had a confidential session on this, but this obviously in public, we want to make sure all our documents are out there so our public can see the same documents we have. So just, it's a timing issue really. It came out in between meetings. So just for completeness, we've put the white paper on the agenda, so it's there. I guess the key thing will be as we move forward, we'll need the following on documents to understand the implementation. So this is the direction, but again, we'll need the operating framework, the human resources framework, and the draft legislation before we can come up with our plans, which we can then engage with patients and public about how we're going to progress.
Okay. Any further questions or comments on that? Okay. Which brings on to the performance reports then. Wendy, finance and contracting. I can't hear you, Wendy.
Sorry, can you hear me now?
Yeah, that's fine.
Is that better? Thanks. So we've got the report at month 10 today. And really just two main items to draw your attention to. And the first one would be in sections 2 and 3, that we continue to have cash and payments well managed. And although it really pains Matt that we haven't got full 100% on one of those metrics, we are very close to 100% on both. That being a key indicator for the national team in terms of COVID and paying suppliers on time. So the second thing would be in the OCS, we have an updated forecast outturn position, which reflects findings of internal work that we do every month. But in this month, it's regarding CHC and the effects of the hospital discharge programme. So as we move forward, we constantly look back in terms of what patients did we have. So we're there comparing our actual patient cohort, if you like, against the expected cohort, which was the theoretical cohort of patients on which we set a plan against. And essentially what we have is that our actuals are coming in lower than our plan. So we have now altered the forecast to make that apparent to the centre. I've updated the risk section at section 12 this month. I'm trying to just bring out there that one of our major concerns currently, then our residual concern, is around allocations and the extent to which we get more allocations or we have allocations withdrawn from us. And in that regard, in terms of an item which we've spoken about at governing body over a few months now, with prescribing and the month 1 to 6 retrospective claims, where again our actuals came in at lower than our assumed spend. NHS England, since I wrote this report, have made the decision that they will now remove allocation from us to reflect that 861,000. So all of the things being equal, what you'll see next month is our forecast outturn surplus being 861,000 less. So that's all in line with discussions we've had previously. And I think that's it from me. So happy to take any questions.
Okay. Any questions on this paper for Wendy? Seems a fairly positive update.
I'm trying.
Fine. Okay, we'll move on to your next paper then, which is the 21-22 financial planning update.
Thank you. So I guess in a normal year, you would have expected by now to have seen lots more versions of the financial plan. So you'll remember that I brought a theoretical plan to confidential session back in January. In fact, we had 2 scenarios that may have transpired. But for the reasons outlined in this paper, we're just not in a position to bring any kind of financial plan to governing body at this stage. So again, since I wrote this paper, there's been a further update from the national team, which we had last week on the 24th of February. Essentially what the national team are working for is they're working towards an agreement with Treasury for the first half of the next financial year where possible. So they're looking to have a settlement that covers the first 6 months of the financial year. But they may not get that, and they may only be able to achieve a settlement for the first quarter. But the regime that they're looking to put in place is something that looks very similar to the month 7 to 12 regime for this year. So that would include, for example, the retention of the blocks with NHS providers. And so I've set out in this paper just a quick reminder of what were the kind of parameters that we were given back in December. They seem to be what we will end up having to work to. when we actually get this guidance, but the timelines are looking really tight now, because as of last week, the advice was the discussions with Treasury may take another 2 weeks to conclude. So we wouldn't know until mid-March whether we had a half two, as they call it, so the first 6 months, or a first quarter settlement. And obviously then that would need to be communicated out to all of us in terms of what that meant. So this paper is just to give you the latest information on that, and to kind of, so the situation we find ourselves in is that I can't bring a plan to governing body to sign off prior to the start of the financial year if we go with our normal governing body routines. So the recommendations at the bottom is to ask you to note this update, that the likely timeframes for receiving formal guidance, so that being probably late March, very late March, and that the fact that we'll then have to work at pace to produce a plan. So I'm thinking along the lines of the arrangements that we put in place for signing off or agreeing the month 7 to 12 plan with governing body. And my second point is I'm asking you to advise me on the process that you'd like to have in place for seeing a plan and agreeing it. And then just asking you to note that I will bring further updates back as soon as I can. When we have anything to share with you, that I will. And so that's the nature of this paper, Richard. I'm asking for governing body to consider what process you'd like to have. My advice is it needs to run outside of the ordinary governing body meetings. It needs to be something that we can react quickly to. And my suggestion would be something along the lines of the month 7 to 10 arrangement. Might be suitable, where John and Richard, Chris and I took that business. So that's my suggestion, my recommendation.
Thanks, Wendy. John, I was turning to John anyway, but he's already put his microphone on, ready to talk. So after you're gloating that you're no longer a CFO and don't have all this stress, as the audit chair and things, if you want to comment on what you think would be the best process and question.
Well, I mean, I'm just conscious about what Wendy said about the need to work at pace when we get the information that she needs to be able to complete budget setting. And so I think that, re-establishing the subgroup that we had last summer, autumn time would be a good idea, because it would help Wendy be able to just finish off and develop the work necessary to get budgets in place as early as possible in the new financial year, and to bring something to the governing body as soon as possible as well. So I think having that process in place I hope, Wendy, would support you in being able to bring things to a conclusion. I suppose it's unsatisfactory what's happening, but it's unavoidable, I guess, really. And in that context, if people are happy with that, it might be that just, Wendy, you might just update us on, what have you been able to do anyway in terms of baseline budgets, efficiency, contracting, in terms of the preparation. Are you well on with the preparation, despite not knowing the sort of total position?
We are, John. I mean, in the background, we've got a model that's now got several different scenarios in it. So the fantastic thing that we have is that we were well ahead. So prior to COVID hitting, we had a CCG plan worked up of what we thought our plan should have looked like. We hadn't negotiated or concluded the contract negotiations with, for example, TRFT. We hadn't done that. But from a CCG perspective, we got a really strong idea of what activity looked like and what that valued to, and of service changes that we were going to be proposing through QIPs and other things. So we had a lot of the groundwork done. So we still have all that to hand. And I think, what we've been doing, so even yesterday we were taking on board the direction that the national team have been able to give us and the actuality of how we knew life used to be. And we're modelling these things through. So we're using both those things to create different scenarios. In reality, some of those scenarios will be close to what we are then given, and we will be able to move quickly. But that's what we're doing behind the scenes, to just get in a position of being able to move quickly. So yes, it's not all doom and gloom. All is not lost. We do have information. It's just not clear which thing we're going with, which model, which scenario.
Okay, Jeff.
Yeah, just from the last paper, Wendy, it seemed as though you got the easiest job in the CCG to then end up with the most complicated. I mean, there's so many uncertainties there, isn't there? But in terms of like what the budget is and when you'll get it, I suppose the question is, once you know what the budget, what's the likely sort of timescale scenario of sort of someone wanting a response to that? And I sort of agree with John in terms of then sort of saying, you know, it's almost like if you knew the budget was going to be the same, we still obviously have to have a plan. There's almost like a high, medium and a low offer, isn't there, as far as sort of where we might, you can sort of put a bit of a skeleton sort of on that sort of behind the scene. But it sounds like, as you say, you have actually modelled that you've sort of prepared. There's some degree of preparation, even though you don't know actually what the budget is. But yeah, I accept as then say if it was then put through the normal sort of streams of sort of how we work, would that take sort of 3-4 months till you've sort of signed off? And if it's like at the end of March and we're sort of starting that year, it can't. We obviously need to be working quicker to that, don't we?
We do, Jeff. And in terms of timelines, I mean, I'm just looking back at my notes from the meeting. So it looked like mid-March guidance and templates coming out, that this is the kind of best case scenario. By mid-April, ICSs and therefore organisations needing to make returns back to the centre to say what our plans are, because led into all this is we're going to have the same situation as we did in 7 to 12, where some allocations are going to come down through ICSs. So we will have an idea about our CCG plan, which the centre are going to work up based on their core assumptions. We will obviously have our version of that. We'll then have to compare the two. But the third comparison will then be with the system allocations. These things won't agree. They just simply won't be the same numbers. And therefore there'll be layers of discussion. So there'll be internal discussion required, and then there'll be external discussion required with the ICS. What we're seeking to do is have as much information about what we believe our internal position ought to be, that bit's done. And then the thing that we're really kind of concentrating on when we do get the guidance is how that marries up with the allocations that the ICS get. And at least we got some form with that, because we had to have those similar discussions at 7 to 12 with large groups of DOFs across the whole ICS. So as I say, at least we've got form there. We've rehearsed that once.
Thanks.
Okay, Debbie.
Hi, Wendy. You mentioned just a few moments ago about quips, and I just wonder what your thoughts were with regard to that going forward then. So do you feel that, I mean, we had to kind of suspend the quips, didn't we, last year with the financial regime that we had? So do we have some that we could almost like bring back off the shelf to apply this year? Will you have to start to devise brand new ones? And possibly, I know some of these questions you perhaps can't answer empirically, but you know, will it be 6 months worth of quips, because we might be in a 6-month regime before we get to that point? You know what I'm trying to say? But I just want your thoughts. You don't have to. I'm not going to hold you to this in a few weeks. No.
Well, that's appreciated. So quips are interesting, because to the extent that they are just sensible things to do to constantly transform services for the benefit of patients, then ideas for that they come up all throughout the year. So there have been there are a number of ideas of that nature kicking around currently. So the prescribing team, for example, the meds management team have got a couple of things which we're working with them on in terms of trying to describe what that would mean for services. Because it would strike me that whether or not there needs to be a financial efficiency linked to them, if they are transformations that make sense to do for the good of patients, we can still do them. And I think what we previously called QIPs, we might just need to take a slightly different approach to that, because for some things they are a sensible, reasonable thing to do for the benefit of patients. There may be no financial transaction that ends up having to happen in the first 6 months of next year if things are blocked. But if there is operational capacity to do those things, we could, I think by agreement, still consider that we should do them. So I think in a roundabout way, what I'm saying is, I think we should still have some kind of process that looks at what would our QIPs be, what would our ideas for QIPs be, just accepting that we may not need to enact them, or we may not be able to enact them in the first half of the year for a financial purpose, but they are still there, ready to go for when the world does return to normal. And I am not convinced that we won't need to do some kind of efficiency schemes anyway, because I think until we've seen the allocation, we just don't know. Have I just spoken complete nonsense, or does that make any sense?
No, I mean, we're in a world of uncertainty anyway, and I know for you, you had the last year of complete change and change and change again. But I was just wondering whether you felt that you were going to have some QIPs, you could already see them coming down the line, being asked to do these financial savings, or they were just perhaps not spoken about yet.
Yeah. So there was a statement that played in at some point around Christmas time or since then that said that there would be additional allocations to kind of make good efficiencies that couldn't happen. But I think until we see these allocations and understand what that means, and is that a complete separate funding stream, it really is difficult to know. It really is difficult to know how that plays in. I have nothing else other than that. No knowledge other than that.
Okay, that's fine. Great, thank you.
Okay, John's thought of another hard question.
Well, I was just going to add to what Wendy just said there, because I remember, Wendy, I think it was January, when you gave us a first look at the financial plan for 21-22, because there was that, buyout of the efficiency. When we looked at our likely spend versus the allocation that we should get under normal circumstances, the level of QIP requirement was significantly less than the level that we've been used to delivering historically. And so I was hanging on to that, really, that we do need to make some preparation for efficiency savings, but I was anticipating that the level of QIP and efficiency would be lower than we've been facing in previous years.
Yeah, that's right, John. It did look like that, didn't it? It did play through like that. And I think we just literally have to wait and see. There are, the statements in the letter on the 23rd of December that said the allocation that we could expect to see would be the one that was in the long-term plan, which therefore is the one that I used in that modelling back in January. But with pots like growth money going to the ICS, and then a discussion needing to happen about how that's allocated out, that then could affect how much that allocation increases by, depending on the outcome of those discussions. So yeah, we do have to wait and see, I think, at this stage.
Okay, Ian.
Yeah, thanks, Chair. It was just an additional comment in response to Debbie's question, which was really good. I think in my mind, Debbie, it just projects ourselves back in about 14 months now, a year last January, where we were looking at our financial plan for this year that we're just going through at the moment, and we were talking in the realms of 10 to 12 million pounds of efficiency. And we got schemes that were lined up in that space that we were going to press the green light on as a governing body and in conjunction with partners in the system. And though, in my mind, those schemes have probably not gone away, but we need to do a bit more work in the background and further assessment as a result of COVID. Are they still deliverable? Has anything else come on the back of those? So it's that we probably won't be standing from a standing still perspective when we do come back to that discussion, Debbie.
Yeah.
Because there was quite a lot on the books that we were articulating that it was not only for efficiency, but in the main to improve patient pathways and quality, and as a result drive out some efficiency. So those are still on the stocks that we'll need to have another look at them, I'm pretty sure, pretty quickly, and that's where we can get. I think we can get some traction pretty quick back on those schemes should we need to. Okay, thank you.
Okay, so is the board happy that it delegates support for Wendy to me and John and Chris to get this through, so we have a financial plan for the start of the year, and then an update obviously at governing body as and when it becomes more transparent? Yeah, I see. Simon's discovered the new button that says yes rather than the thumbs up. So yes. Keep adapting it, don't we? So yes. So Wendy, that's the plan. The board does agree that's
marvellous.
The working group will work with you to develop the plan.
Thank you all. Thank you.
Okay, delivery dashboard then, Ian, with a brief COVID and COVID vaccination update as well.
Yeah, thanks, Richard. So I'll just kind of talk you through that. I'll do just a quick bit on the COVID position, because it just helps set the context for where we are on this report. Because although we're flagging it as obviously the March governing body meeting, the data's coming through from January, which was right in the heart of what was a really challenging period for the Rotherham Place. So again, the current view on our COVID position in the hospital is that it is improving from previous month, which is good. Our numbers of COVID positive patients in the hospital setting are reducing on a weekly basis, as is the prevalence of COVID in our community, although we are continuing to watch that really closely with partners across the Rotherham system. I'll come back to the vaccine right at the end, but I think that intro view in terms of the COVID position just kind of is a bit of a sobering one when you start then to look at the impact on our performance, which is pretty consistent in that challenging area at the moment. And if your colleagues are looking at enclosure 10C, you can see within there that our challenge on key areas, particularly around RTT, referral to treatment at 18 weeks, is being really challenged in that space now, and continues to be consistently. We're performing better than the national average, as you'll see on page 1 there, comparatively, but we're continuing to see numbers of patients rise above that 52-week wait position, i.e. over 1 year for treatment. And the challenge with this is that we know that our elective plan has been hit really, really quite hard as a result of COVID and our inability to undertake elective care to the levels that we would have wanted to. So we are starting to have that active dialogue now around recovery, but it will take a while and a good number of months to kind of start to really see some good recovery in that space. In terms of other key parts of the performance report, just to flag that our diagnostic position again remains challenging, as it does at a national level on 6-week waits for diagnostic, again linked to our positions on 18 weeks. The A&E activity in terms of flow through the A&E department, we continue to see lower numbers than we did at the same time in the previous year, and I keep reminding colleagues that the previous year it was lower than the year before that. So that kind of impact at the front end in terms of numbers in our A&E has not been to the level that we would have expected through a winter period, but the complexity of patients and those that have been presenting through this latest COVID pandemic have obviously been significant, and therefore put some real pressure on our A&E department and therefore our hospital. Our IAP provision again is standing up to performance, but again we're seeing an increase in activity through IAPT and the IAP view across the Rotherham Place, utilising not just the RDASH provision but also the IESO digital platform for IAP, which has been received positively. You can see within the report there has been slight improvement in our cancer performance at 2 weeks and 31 days, but we also kind of continue to see the challenge and a significant challenge on our 62-day performance. And again, that's replicated across South Yorkshire and wider at a national level. So yeah, quite a kind of sobering picture in terms of performance, Chair. But I think I'll just pause there and then come back to the vaccine programme if there's any comments on the report by exception, if I can. Is that okay if we treat it like that, Chair? Thanks.
Yeah, thank you, Ian. Yeah, it is sobering, but it's sobering on a national level, isn't it?
Absolutely, yeah. Rotherham's not an outlier by any stretch at the South Yorkshire or national position. These are all performance metrics that are mirrored regionally and nationally.
Yeah. Any questions on that for Ian? Okay. Do you want to just give a very quick?
Yeah, so since the last time we met as a governing body in early February, you recall that we were working towards the delivery of the top 4 cohorts of vaccination, which were the 70 pluses, 75s, 80 plus, including clinically extremely vulnerable care homes and staff in both health and care sectors. So if I just update where we got to by the 15th of February, which was the target set by NHS England, for the 70s, 75 and 80s, we got over 95% coverage of our vaccine take-up, which is a fantastic effort. And again, a huge thank you to all our primary care colleagues, staff working within there, and also the volunteers. Really good achievement there. We managed to achieve delivery against the housebound element of that cohort as well. We were also successful in delivery against the requirement to vaccinate and offer vaccine to all our care homes for both staff and residents. And again, a real positive uptake there. Some further continued targeting of some staff groups associated with care homes, and we're actively working with our partners on that. And again, when we look at the wider workforce, we vaccinated over 11,500 of our Rotherham workforce, which again was a really good effort. So we're really pleased of that. I think what we don't stop now, because we just, I know Jeff uses the analogy of 3 miles into a 25-mile marathon. We now just focus our attention on the kind of 50 plus cohorts, which the national ask is by the middle of April. So we're well into that programme now, being at the start of March. And we're also focusing on what is called cohort 6, which is clinically vulnerable, which includes carers. So our vaccine programme's rolling out into that space now as well. And again, we've started off on a positive foot for that. I think just to note for governing body in the public domain is that we are, as well as channeling all that activity and time into first dose activity, we're just on the cusp now of bringing patients back for their second dose. And it's really quite a logistical challenge for us to work through that, but we're confident of delivery of that programme to deliver both first and second doses. I think what we're really keen to say though with the whole vaccination programme, and I know we're really passionate about this in Rotherham, is just around the public messaging of just because you've had your first dose or even your second dose, you still need to follow the rules and guidelines of hands, face, space, social distancing wherever possible, because we really do need to get that coverage and to maintain those kind of key areas that we know will suppress the virus in our community. So I'll pause there, Chair. I could take any further comments or questions, or if Sue or any of our CDs have got anything to add who've equally been putting the same amount of time in, please do so.
Yeah, amazing effort everyone's made this amazing effort. Just need to keep it going to achieve all our milestones of everything being reopened in the next 3 to 4 months. Any questions, comments, Jeff?
I think we might be 5 miles in now, Ian, just trundling along by Meadowall, but just about to hit that hill on the other side. We're still a long way to go, but yeah, it's coming on well.
Okay, any other questions, comments? No. And of course, a big thank you to all the volunteers, because actually none of the vaccination centres would have been able to run without all the people of Rotherham volunteering to help out in all the ways they can. Okay, right. Moving on then. Sue, patient safety and quality.
Thank you, Chair. go through the report and take questions if that's okay, with mention some of the highlights. So on page 1, we start the report with the infection prevention control update. The CCG infection control nurse has now undertaken a walk around at each of the vaccination sites to offer advice and support about infection control, ensure ongoing safety, look at any changes in practice or changes to the sites that we've made in response to running them slightly differently, and giving advice where that's been appropriate, and that's been well received. Even the bits about removing biscuits. There's a piece of work at a regional level looking at procuring. We will be supplied with the show and tell boxes to facilitate hand washing training, and these are it will be part of the support process into care homes and offering advice and support and to care homes as part of that ongoing training. Also at regional level, NHS England and Improvement continuing the work to review and address nosocomial infections, the hospital outbreaks and transfer of infection between hospitals, which we're all involved in some of that. Page 4 updates on the TRFT mortality data with a slightly improving position towards the trajectory set in the improvement plan that they've got that heads towards March this year position. That data is not available yet, so we're still looking at some slightly older data. The safeguarding section starting on page 6 with a summary of the national response to the threat of terrorism. At the beginning of February, also, the CCG hosted a learning event about the liberty protection safeguards, which was attended by 26 multi-agency staff. We'll be building on this training. It highlights the changes between that will affect how the deprivation of liberty is authorised in the future. A training session for governing body members was held prior to this meeting to give an overview of how those changes will impact on the CCG. The Stovewood investigation into non-recent child sexual exploitation and abuse continues, with all partners supporting in this. There's a press release from the 15th of February included in the paper, at a link there. Going forward onto page 8, the care home update shows the CQC ratings with over 72% of adult care homes rated as good, and 2 new services awaiting a rating. The CCG continues to work with the partnership, working partnership with the local authority to support those homes where improvements are required. Moving on to the next page, there's an overview of the activity in the multi-agency safeguarding hub there on pages 8 and 9. Through into the CHC update. There's a link to the full hospital discharge guidance, should you have a burning desire to read it all, which was published in August last year. This is the operating model for hospitals, CCGs and local authorities to work jointly to facilitate hospital discharge and post-discharge support for those who need it. The model identifies 4 pathways from 0 to 3. Dependent on how much care and whether it's a new package of care that someone requires to ensure that they can be safely discharged from hospital when it's appropriate to do so. Alongside this, the CCG Continuing Healthcare team have been undertaking a catch-up of assessments which were deferred under the previous lockdown guidance and the reintroduction of CHC assessments and all those processes that support that. This guidance was also published in August last year and is included at the link on page 12. Tables 1, 2 and 3 show progress against the above trajectories, and as you can see, the number of deferred assessments, the work there is progressing well, so fingers crossed there, and progress is being made across all areas. The quality standards that are related to continuing healthcare were paused between March and September last year. As you can see, the CCG is achieving Part B and is already above the national average achievement for CCGs for Part A, and working towards last year's very favourable position for all three parts. The work to improve achievement on Part C obviously continues. Page 14 includes an overview of the CQC GP practice ratings for Rotherham, and start with also under there the briefings from the quality visits to 3 GP practices which were undertaken during December, January and February. There's follows a brief update on the work the Foundation Trust are undertaking in response to the recommendations from the CQC. In support of this, the CCG are working with the Trust and NHS England and Improvement to complete a quality risk profile, which enables the Commissioner and key partners to have a strengthened view of the current risks. This then informs a structured approach to managing any quality concerns. This work will report through AQUA, through Contract Quality, the governing body, and the NHS England and Improvement hosted quality surveillance group. The Trust Chief Nurse also attended AQUA this week to give a detailed update on progress against the CQC action plans and provide a good level of assurance about progress. John might want to add to this one. I've just got one other thing to mention. Towards the end of the report, within the maternity update on page 19, there's a reference to the December 2020 Ockenden report, which covers emerging findings and recommendations from the independent review of maternity services at the Shrewsbury and Telford Hospital NHS Trust. This required all trusts to provide maternity services to implement 7 immediate and essential actions. The NHS England and Improvement required Trust to complete an assessment tool and implement 12 clinical priorities. TRFT have confirmed that they've done this. The South Yorkshire and Bassetlaw local maternity service have oversight of this, and the CCG contract quality meeting is monitoring the position with reports going there on the completion of the assessment tool and the completion of any actions that were identified under that. John, did you want to add anything about the CQC update from Angela at AQUA?
Just to confirm really what you said, Sue, that we got some good assurance. I think the Chief Nurse was able to demonstrate some really good progress in terms of implementing and delivering the action plan, despite the competing priorities of COVID and other issues. So we were pleased to get that assurance and to hear some of the things about what might feel different at the hospital now that they've implemented that. I think it will be interesting to see, won't it? So when the CQC do come back at some time in the future, just how they that they view what the current position of the hospital trust is. But we got some good assurance about the progress that's been made.
Happy to take any questions.
Okay, thank you, Sue. Any questions for Sue? Okay, shall we move on then, Sue, to patient engagement?
As you'll see from this report, COVID vaccination programmes at the top of most conversations, and particularly as we're directed to move on through the priority groups, a lot of that focuses around people wanting to know when they'll be vaccinated. Do I fit into these groups? Am I a carer or aren't I a carer? When will my second dose be administered? Because cohort 6 is a large group, this will take some time to get through. It's particularly complex, and as I've said, it is a large group there. There's also, as I've said, the questions around carers and how people ensure that they're included in the group if they're an unpaid carer. And how much support has been given by them in order to qualify for this category. So those conversations are ongoing and involve other groups, not just the CCG, with Helen working into a lot of the other groups. There's still a big push to reinforce the message, as has already been mentioned, about following national guidance such as hands, face, space, even after vaccination. That's really important. We're reiterating that at every opportunity. The head of communications is closely involved in the vaccination planning to ensure that consistent messages are communicated. As mentioned previously, the Friends and Family Test restarted in December, and going forward, the priority work for TRFT will be on a what you said and what we did approach. And page 4 includes an overview of work undertaken by our patient participation manager since the last report. Much of this involves coordinating the volunteer support to vaccination sites, as there are over 200 volunteers signed up to undertake the marshalling roles on vaccination sites. The report finishes with a positive comment from a patient following their vaccination. I can't remember which site it was at. I think it might have been St Anne's. Good afternoon. I wanted to take the time to say how impressed I was with the vaccination service. I went today and would like to say how well organised it was and how efficient and pleasant the staff were. It's good to get some positive feedback, and that's just an extract from the feedback that we did receive from that and other patients who've attended.
Thank you, Stu.
And I'm happy to take any questions on that, and also to ask Debbie if there's anything she wants to add on there.
Thanks. So you know me, I can never be quiet, can I?
Yeah, well, we're very similar in that way.
Yeah, we do. Nothing really, everything that you've said. I mean, obviously the two big prongs in the last few months have been working with all our partners and having those dialogues. People like Cancer Collaboratives and RDASH and for the mental health, and VAR for all the volunteers, and really exploring with our volunteer partnerships how we can maximise really going forward beyond COVID, beyond the vaccination success, maximising the volunteering process and giving them as many opportunities as possible, because it's just such a positive experience all the way around. So that's really good. And just to say that by mid-February, we were the volunteer programme was actually delivering, I think this is phenomenal, 4,400 hours of support to the vaccination programme. So that's how much coordination is going on to actually make that happen for everybody. So I think that's great too.
It's exceptional. And I just think it says something really positive about Rotherham and the people in Rotherham.
Okay, any other questions, comments? I mean, I think the reflection on the vaccination centre as well is the reason why he was talking earlier about we need to keep to the guidelines is some of these people you see in the vaccination centres haven't left the house for a year. And it's amazing what people have gone through in the last year they haven't left. And therefore, sticking for a few weeks to the rules will allow these people actually return to having a relatively normal life. So
it's really important that we keep them safe when they're attending.
Yeah. Okay. Right. Thank you then, Sue. Shall we move on then to Ruth? The Green Plan.
Thank you, Chair. So this is not a new policy area. We used to call it the Sustainable Development Management Plan. It's now been renamed and rewritten. So in that context, it is a new policy, but it is now in line with the requirements that NHS England have asked us for. It is presented here for ratification, having been approved by Aqua. I am happy to take questions on it.
Okay, are there any questions for Ruth?
Yes, yeah. Can I?
Oh, well, Nick, you go first as you're talking, and then Jack.
Nick, all right.
Yes, I was just going to say, yeah, no, I like the inclusion of active travel in the plan. I just wondered whether it could be strengthened a bit further by having something about working with partners, because it's very difficult for any organisation to achieve active travel plans without working and thinking across the system. It was just sort of a small comment on that.
We do work with RMBC quite regularly with the active travel, especially with all the bus timetabling with the SYPTE and everything else that the RMBC do. So we do that. It might not mention it in the policy. I can certainly have a look at that next time we look at it.
Yeah, that's great.
Okay, Jeff.
Yeah, I picked something up from an email a week or two ago from a organisation saying that actually asthma inhalers are a significant issue in terms of ozone. In terms of that, I think it's surprising because we've all swapped over to CFC-free inhalers a few years ago, but obviously what we've swapped over to is better than that, but still an issue. But I did pass it through to Stuart Lakin, who said that the prescribing were looking at that. I can't remember the percentage of sort of what it was, but it's actually a significant amount of what sort of the NHS sort of takes. So you know, potentially sort of dry powder things, but prescribing were aware of that, and it's something that we're looking at.
Okay, thanks. So, are we happy to approve the green plan as part of our statutory compliance? I see nodding of the head and other people discovering the yes button. Okay, and then to ratify the green plan. Although I do think now with digital, we could have had it on green paper, Ruth.
Apologies, Chair.
So happy to approve that. That's fine. Moving on then to the governing body assurance framework.
Thank you, Chair. If you cast your mind back, we did quite a large development session on this last year when it was in its early stages, when we were first developing it. It's since gone through a number of alterations via OE. Aqua went through this line by line yesterday, and we're assured on the process of the development and any updating that's going to take forward going forward take place. The time frame for that development was attached, if you remember, to the risk management framework that we brought. I think it was a couple of meetings ago. I took a couple of actions from Aqua yesterday. One is a meeting, which is already in the diary now, with the lay members to go through this so that the lay members have the clarity about the document that they felt that they needed. It is here for assurance. I'm happy to take any questions.
Okay, thank you, Ruth. John, just feedback from Aqua, and specifically were internal audit happy with everything? You're still on mute.
Yeah, can I just give a little bit of feedback? I mean, I think we're in the middle of the work that internal audit are doing on our head of internal audit opinion, and we want to make sure that we get the right outcome on the head of internal audit opinion. So we spent some time yesterday at our audit committee reviewing the GBAF and trying to understand some of the things that we perhaps need to develop or improve on. And I think it's really important that we need to maintain our processes and our review of GBAF despite the competing priorities that we've got at the moment around COVID. I think we're really looking for OE to continue the work that they're doing in terms of the regular review and oversight of the GBAF and the risk register. That needs to continue, and we need to make sure that that's evidenced and effective. I think the second thing that we talked about really was, you know, the need to still try to make progress despite the difficult circumstances that we're in. In some cases, the risk appetite that we've got, our actual position against the risk appetite is we're above the risk appetite, and there is probably in some cases a requirement to develop further actions that tackle our relative position against the risk appetite. And Jason and Ruth were talking about yesterday. We're talking about how we might include those a section in the GBAF for the additional actions required, but where we are in terms of some of the areas on the risk appetite. Can we still make risk improvements despite the other priorities and the workload that we've got at the moment? And we were hoping that we could, but that again will be for OE to review. In terms of the section on assurance level, there was some areas where we were red and amber, and again try to tackle those. And then we just talked to really around our overall understanding as a governing body and an audit committee around the new form of the GBAF. We like it, but it's probably a little bit more complex, and just we're we're going to do some more work, as Ruth described, in terms of reviewing the GBAF with the audit committee members. And the other point was really, we've got to this position now, but is there any further work for a fundamental review sometime in the early part of the next financial year as we reassess the risks that we face and reassess the risks under each of the objectives that we've got. So probably we may need to come back to that. You know, I'm just thinking about, you know, the very latest things like the white paper. If COVID impact reduces, can we reflect that in the GBAF as well? So just keeping it under review as well, really. So I think there was a few things arising out of audit committee that that the audit committee and Ruth will take forward, hopefully, and that we look for OE to work on.
Okay, thank you, John. Ian keeps going in and out of connections. I have to keep reconnecting for anyone wondering where Ian disappears to. Sue, then Chris.
Thank you, Chair. I think one of the things for me is that the frequency and the depth of the discussion that we have about all of these documents, the other elements of it sitting beneath it as well, for myself, shows the level of assurance that I personally want to take away, not just for my sections, but for all the sections there. There is in-depth conversation in a variety of Aqua and OE around each element and every line, to make sure that when we discuss this at governing body, that level of assurance is of that we would expect it to be. Does that make sense?
Yeah. And Chris?
So just mine follows on from that, really. So I think when we go through these risks at the management executive meeting, we find that some of these are quite difficult to get to a narrative and decide on an actual risk. So we would really welcome, if there are any areas the governing body does have, would wish to challenge our ratings, we'd be more than happy to do that, because we do challenge ourselves as well. And because things move so fast at the moment, so what we used to call a year is now a week, isn't it, in terms of NHS terms, these risks change so quickly. So if anyone does have any challenge, it would be very welcome.
And that challenge can be offered in this public meeting, but can actually be emailed when you've had time to think about it later on. So the GBAFs are always reviewed on a regular basis, aren't they, Chris?
They are, absolutely, but like I say, things move so fast at the moment that you'd be reviewing it every day, almost literally. So it's just keeping us up to speed.
John?
Well, Chris, really recognise that that what you've just said, really, about the pace at which things happen. I think that two things. One is when we've talked to the internal auditors about their head of internal audit opinion, their concern was that during this financial year, the challenge that's come at governing body and Aqua level has been less than in previous years, and we know the reasons for that. But that's their headline message back to us. And I think the challenge from the audit committee back to the chief officers and the OE is probably really around what do we do when the risk is higher than the risk appetite, and the challenge is can OE, what can the OE do about that? So those are the two challenges.
Okay, thank you. Any other comments? So we recognise the good work that all that's been done and the continued need to keep considering these things. Is there anything else we need from the paper, Ruth?
That's fine, thank you.
Okay, fine. All right, moving on then, corporate assurance report.
Thank you, Chair. So if I may, I'll take this report as being read. Going forward, in line with our previous discussion around the GBAF, I've asked that the GBAF and the risk register are hyperlinked within this document. So every time you see the corporate assurance report, you'll get the most up-to-date version of the GBAF and risk register. So you're not actually waiting for that to come to governing body. You've got it there in front of you. I thought that was possibly a good idea for us to be aware of that. And as most of you will be aware, the declaration of interest return has just started for this forthcoming year. So we'll be reporting on how we're going with that going forward. And that's not actually in the report, but I just thought I would mention that so that you're all finishing your declarations of interest returns and sending them back. I am happy to take any questions on this corporate assurance report Q3.
Okay, comments, questions? Okay. Thank you for the report then, Ruth. We just move on then. We've got minutes from our other meetings. Janet, primary care meeting from January.
Thanks, Chair. These are the minutes from the primary care meeting on the 12th of January. They're here for information. I'm happy to take any questions. Just a couple of bits to note, really. One is we took an update on the primary care estate strategy review, and the second thing was, although it's somewhat sort of events have gone on quite a lot since then, which was then the process about freeing up GP practices to support the COVID vaccination programme. So as I say, things have moved on since then significantly.
Yeah. I think every meeting needs to be on every week to actually adapt to the changes that's happening. Any questions or comments for Janet? Okay. John, then the Aqua meetings from January.
Yeah, this was the meeting from January at 21:14 on the issues to escalate to governing body. We were just feeding back really the assurance we're taking about our financial position this year and our ability to deliver on the financial targets. And you know, Wendy's really confirmed that today when we were looking at the financial report. We referred to annual accounts progress report, and we've looked at the preparedness for preparation of annual accounts, and we took a lot of assurance about where we are in the finance department in terms of readiness for the annual accounts, and we feel quite confident about that, and that's been backed up really by the feedback we've had from external audit on the work that they've started to do as well. I think the sort of like main issue that we were worrying about was just really around getting the right head of internal audit opinion, and we're hoping that we're addressing that now through the work we've been doing on GBAF and risk register.
Thank you, John. Any questions, comments for John? Okay, the HEG minutes, Chris.
Again, Chair, they're here for information, just for keeping everyone in the loop and for transparency. So I'll take any questions if anyone has any, otherwise we'll just treat them as info for information.
Okay, thank you. Any questions? Okay, members group, Jeff?
Yeah, same really as everyone else from January, just went through extending 10 years, discussion about vaccines and discussion about future commissioning, but if anyone's got any questions.
Okay, I don't see any questions. Okay then, we're just moving on. The glossary, there's no other urgent business being raised with me. There's nothing that needs to be escalated and no additional risks raised. As we went through the GBAF, I hope there's no other risks that we haven't missed. To which then we'll bring this to end with an exclusion of the public, because we will continue on with a confidential meeting because the representatives of the press and other members of the public be excluded from the remainder of this meeting due to the confidential nature of the business to be transacted, publicity of which would be prejudicial to the public interest. Therefore, the date and the time of the next meeting will be 7th of April at 1 o'clock. We look forward to seeing you there. The confidential meeting will start at 20 past on my clock. Okay, see you then.